neurosurgeon and spine surgeon, and doing a wonderful quality of work in Bhubaneswar. He's a senior consultant at Care Hospitals, Bhubaneswar, Odisha, and welcome you, Dr. Atman.
Thank you, sir.
And it's been a wonderful pleasure. We worked together at Gurgaon some time back, but then he heads a very busy center now and doing a great work. So, to conduct today's sessions, there are panelists and moderators. My co-moderator, Dr. Prakash Nair, he's from Chitra, and everybody knows him. He needs no introduction. Wonderful, young again, dynamic endoscopic neurosurgeon. Due to he's being in Calcutta, so he won't be available to us on video, but of course he will be there on audio. And our two panelists today are Professor Sachin. He is a professor of neurosurgery at All India Institute of Medical Sciences, New Delhi, and Dr. Jayesh Sardara, he is and Mumbai, Fortis Mulund, and both of them are wonderful neurosurgeons and doing great work at their places. So I would on over to the moderators to start the proceedings. Dr. Jayesh and Dr. Sachin, please take over.
Thank you, Sumit sir, for generous introduction. And Dr. Atma, most welcome because this is the first NESI webinar. So today we would like to have your more live discussion, and at the end of session, I think we'll discuss about some salient tips and technical pearls of UBE, how it will be good compared to those who are doing interlaminar uniportal, and then biportal. Will compare also, will have your experience in different indication. So most welcome, and we'll start the session. Dr. Sachin.
Thank you, Jay sir. So I'm starting the session. Can we see my screen?
Yes, yes, you can see your
Yes.
screen. Yes.
So this is a 39-year-old female which presented to us with back pain and claudication both. She was able to walk for 200 meters and claudication time was 10 minutes. So this is the scan of the patient. You can see the degenerated disc here at L45 level with a protrusion here at the, you can see a central bulge with canal stenosis. That is what the reason for the claudication of the patient. So the and the CT and the X-ray was, there was no instability and the patient was only having claudication and radiculitis. So we planned for a endoscopic decompression by biportal endoscopy. So basically we do. So can you hear the voice now?
Yeah, you are
Mhm.
audible.
Video voice is there.
No, video voice is not there.
Voice is
So, so this is the setup which we are doing to this. This is the OR. This is KR OR. So this patient positioned in prone position in the same thing where we how we do open surgery. There is no bend or curve at any place of the spine. We don't do hyperextension, hyperlordosis. We don't do that because the scope is very small. It can travel to all those nooks and corners. So this is first the scope. This is a 4 scope, and we attach the saline channel because this is a saline irrigation system surgery which keeps the vision very ultra clear because you don't have any blood, everything is washed out. These are the saline bottles which are connected, and this is done through gravity. There is a connector which we call as TURP pump. There is a person standing here. Whenever we need pressure, we ask and the pressure is provided. This is a 0-degree scope. So initially I used to use a 30-degree scope, but later on I moved to a 0-degree scope. So you can see the scope, it's a 0-degree scope, and it's the sheath on the scope. So that the sheath is a front throwing sheath. I'll show you the water thing. So and this is the whole setup is made with first, this is a craniotomy drape sheet we are using. This is the initial marking how we do. There is something known as a Namaste point which we have designed. There is a point which is actually the summit of the facets. The two facets, if you take a lateral view, it looks like a Namaste, like this. So that is the target point, and this point corresponds to the interlaminar window in the AP view. So you can see this is a Namaste at every level. This is the highest point of the facets in the lateral view, which we call as the namaste point. So you can very well see this namaste at every level. So this is the level we mark. We don't mark the disc level, we only mark this level, because most of the surgery we don't take the AP view, only take the lateral views, because lateral view is that reduces the number of exposures to us. So that is why this is a namaste point which I am describing here. This is the highest point of the summit. I think you can all see. So that is the marking we do. Once we do the namaste marking, then we move to uh, um, the starting point of the surgery. So I do not do unilateral biportal endoscopy. I do midline biportal endoscopy for discectomy and canal stenosis. For fusion, I move laterally. I do unilateral biportal endoscopy. So the midline of a spine is described as a spinous process, but we have divided the midline into three lines. One is a midline, other one is a left midline, third one is a right midline. This is nothing but the thickness of the spinous process which are taking care. So the spinous process is this much of thick. So this is the left midline, this is the right midline, and this is the mid midline. So we are going to operate on the left midline. So with this process, suppose you have a contralateral disc, you can operate on the right midline and start working on the right side. If you have a left-sided disc pathology, you can start on the left side and operate on the left midline. So, and this is a namaste point which you have marked. This is not the disc base. This is a namaste point, which is the highest point of the spinous process. Then we use a 11 number blade to move to the surgical part. So the incisions in my biportal endoscopy is very small. This is not more than 5 mm. So I believe two 5 mm incisions are more muscle splitting than a single 1 centimeter incision. So I take the stab incision and go there and cut the fascia. So these two markings are 3 centimeter apart from the namaste point. So the two, so that you don't have a sword fight while operating on the system. So this is a
इसका क्या
triangulation.
मतलब हुआ?
So the triangulation
उसमें ये लोग
involves
टाइटल ऐसे
touching
देते
the
हैं।
both the ports, so that you
इन्होंने
can have a
इसमें
common
इसमें सोफा गिफ्ट
interest at
किया
the
है ये
center.
वाला।
Understand why the gift, then
So
इसका क्या मतलब है?
this
so once we are done with this thing, we move to the incision. Once the
पूरी
incision
रील का
is
कोई
done, we
मतलब है?
use these dilators. These are specially designed dilators by
हटा लो ना,
Gesto.
अब अपना काम
This
करो।
is the
तो
dilators
क्या
are very small. This is
तो
irrespective of the
काम करो,
normal
कुछ भी कर लो।
dilators we use for UB, which are bigger. So we try to minimize the incision by using a smaller diameter dilator. So the maximum thickness of this dilator is 6 mm. So you don't have an incision bigger than 6 mm in any biportal endoscopy. So once you are done, you put on splitting the muscles with the dilators and make a soft tissue subperiosteal small dissection at the zone space level. Once you are done with this some small dissection, then you put a guide wire through that so that the muscle facial opening remains patent. Once you are done, you move to the scopy portal creation. The working portal creation is the first step. Then we move to the scopy portal creation. So once the scopy working portal is done, same way we do the scopy portal creation. In this surgery, we have removed the concept of triangulation. We just do the portals and start the surgery. And this technique is very fast, irrespective of the traditional way of biportal endoscopy. So similarly, as we have done the initial triangulation, and this is the dilator which was there, we go to then this is a namaste point. So once we are done with the scopy the working portal, we do the scopy portal in the similar way the working portal is done. So once the scopy portal is done, we take the scope. So this is the light, you can see the scope. First we check the saline irrigation with the scope. The saline irrigation has to be adequate, otherwise the space won't be created nicely. So the saline irrigation, the scope through, you can see this is the water connector. So once the saline comes, the saline should have a projectile flow, that is considered as an adequate flow. So this is the adequate saline flow you can see here. So this is going down and moving up. So this is the adequate flow. So you can see once you put the scope, how fast is the biportal surgery. Once I put the scope, within seconds, I can see the spinal lamina junction. This is very fast. The triangulation does not take less than 10 to 12 seconds. So once I'm putting the scope and this is the RF radio frequency probe, both went in, and you can, in a seconds, you can see the spinal lamina junction. Once you start seeing the spinal lamina junction, we can, so this is a spinal lamina junction we have reached. It took me almost around 10 seconds to reach at the spinal lamina junction. So this is the advantage of midline biportal endoscopy, that because it does not have any multifidus muscle medial to the triangulation, so that you don't feel any poking or hindrance from the multifidus here. We are on the just medial to the spinal lamina junction. So this is the spinal lamina junction. If you can see the center, this is the area of the spinal lamina. This is the cranial end. This is the caudal end. So the 9 o'clock is the cranial, 3 o'clock is the caudal, and the 12 o'clock is the medial, and 6 o'clock is the lateral. So this is, you can start, you can see the C. This is the C. C is the curvature of the spinal lamina junction. So this is the RF. You can see we are making a space at the spinal lamina junction like this. So once we make the space at the spinal lamina junction, now we can see this the ligamentum flavum coming into picture. So once we see the ligamentum flavum, then we put the shaver. This is a shaver or a cutting drill. So this is for the bone work, initial bone work. Later on, we'll shift to the diamond drill, which is considered very safe on the nerves and neural structures. So we drill the base of the spinous process. In the midline biportal endoscopy, it is very easy to access the base of the spinous process. The base of the spinous process is the area where the scope will enter the interlaminar window. The incisions and scope is very small scope. It is a 4 scope, so we can travel to all nooks and corners of the spinous, the canal, and remove those blind spots which are actually not seen in bigger scopes. And the vision is very clear because water is continuously, saline is continuously making a irrigation and making the field clean. And this scope is a 4 scope. So the pixeled camera vision you get in a 4 scope is much higher than the monoportal scope, which is a 1.8 scope camera size. So bigger camera gives you more pixeled image and more clarity of vision, so we can see things very clearly. So this is actually the C. So I'm drilling the curvature, apex curve of the C, and making a space at the base. So you can very well see my hand movements. It is like laparoscopy of spine. You have two ports, you just work like laparoscopy. So the flexibility, because we are bidextrous people, so we can allow and operate with both the hands, which have different fillings from each other. So once we start with this, you can very well see the ligamentum flavum visible. You can see this surgery is very fast. The biportal surgery, now we can do a single level surgery, and this is a live surgery. The whole surgery was done in 20 minutes only. So once we are done with this surgery, we have started removing the bone with a Carrison. So you can see I'm removing the bone with the Carrison here, and I use a lot of chisel for a faster work. 0-degree scope gives you a very clear and stock image. You don't get confused with like 30-degree scope. So it is like microscopic vision. So orientation of surgeon is not lost. So you can see the epidural space, the pulsation of the epidural space, and the epidural fat. So this is the caving technique which we have devised, is we call as under the cave. So we no longer do over the top decompression, we do caving, so that the contralateral facet integrity and the laminar integrity is maintained. We just go below the lamina and shave it so that a space is made. This is a 4 scope. The advantage is this 4 scope will help us to navigate to the canal very easily without causing any mass effect. So this is the caving we do. Once we do contralateral caving, we do ipsilateral coning. So coning is you dig from center to periphery in like a cone fashion, so that the integrity of facets is maintained. Now question is how much facet to be removed during the surgery. We say we don't remove any facet integrity. We just maintain the facet integrity in both all the surgeries, in whether it's canal stenosis or whether it's discectomy, so that you don't have to have a fusion, or micro instability is reduced by doing so. So once we are done with the cranial work, we have moved to the caudal lamina. So this is the cranial border of the caudal lamina. I started sweeping the soft tissues out of the cranial border of the caudal. You can very well see this is the cranial border of the caudal lamina. So once we do this, these are the soft tissue which are present above the flavum. So once we remove those soft tissues, we start working on the cranial border of the caudal lamina. So the RF is used to ablate those soft tissue and make a clear field there. So once we do this, we move with the diamond drill to drill the cranial border of the caudal lamina. This I call, here you cannot see the drilling. This we call as mind drilling or blind drilling. So here we drill by tactile sensation, because once you drill, there is a lot of bone dust created to and delays the surgery. In that condition, what we do, feel and drill. We feel the, let's say egg shelling we do, we feel and drill, we feel and drill, and this is a mind drilling technique. So that we use a tactile sensation most of the times rather than seeing it. So it is a very safe way of drilling. You feel, once you feel that softness is gone, we stop. So once we drill this area, you can see the cranial border of the caudal lamina getting drilled off. That is exactly the attachment of the flavum. So once we drill this area, then we'll chisel that part of the area to remove that bone fringes or lip of the cranial border of the caudal lamina, so that the flavum is removed from the attachment. So you can very well see we are continuing in the drilling process. So the biportal, because both hands are engaged, the surgical duration is very, very fast. You don't see any muscle during the surgical process. You won't see a muscle during the surgical process. Whenever we do other ways of endoscopy, we put some instruments and remove those muscles, which is not needed in these cases. We directly go to the subperiosteal plane and start working there. So this is the chisel. This is the curved chisel. I use this curved chisel a lot because this is what is used for the removing the small lips of the cranial border of the caudal lamina. Now you can see I have removed the attachment of the flavum. Now the dura is now visible. So what I am doing, I am trying to remove that flavum. Now you can see the flavum is removed from this attachment. So this whole video is on YouTube. So anybody wants to see that can see it completely. So then we start chiseling on the medial border of the ipsilateral facet, so that the lip of the medial border is also removed, so that the attachment of the flavum is also released. The patient is also having claudication, so we'll remove the flavum completely here. So once we have removed the flavum from attachment, now you can see the dura is visible. So this is a 1x video. This is not a faster video. It looks faster, but it is the original speed of the surgery without any editing. So this is a raw profile. This is from a live surgery. So once this side flavum is removed, you can see the pulsating dura here. Then you move to the contralateral side, and you can very well see the flavum and underneath of the flavum. So chances of having a dural tear is very, very minimal in biportal endoscopy, because you can see everything, literally everything in a bloodless field. So surgery looks like a edited video. So everything is clear. You don't have to push saline. It is continuously under saline irrigation. The clarity is very good in this kind of surgery. So once you do this, then you move and do the remove the contralateral lip of the cranial border of the caudal lamina, which is the contralateral flavum attachment. Then you remove all the flavum around. So we have to take care of the claudication too. So I am removing all of the flavum here. So this is the contralateral flavum which I am removing here. You can see my hand movement on the contralateral side. My scope, my instruments are moving very easily. This is once you do the fascia is cut nicely, then the movement of the instruments are very easy. Some of the people find difficulty in putting the instrument. Because that is the game where you cut the fascia in a cruciate manner, which helps us to have a very fast movement inside the canal. So you see the ipsilateral flavum is completely removed. Now we are removing the contralateral flavum. The advantage of biportal endoscopy is you can access few extra millimeters of the lateral recess, which is not possible in microscopy. So the few millimeter extra of the flavum removal helps us for clearing complete lateral recess. We clear almost around 5 mm extra of the lateral recess, where we find the blind spots. That is why the endoscopy is unfamous or people do not, people say it doesn't have results, but Biportal we can access those blind spots very easy because of the 4 mm scope. So 4 mm scope can travel underneath the lamina and can remove those blind spot. I'll show you the blind spot. So this is the flavum above the exit traversing route, and this is the contralateral facet. You can see I have not violated any integrity of the facet. This is the IAP SAP, and this is the above it is the IAP, and this is the attachment of the flavum. So how beautifully we'll remove the flavum from the attachment from the SAP. The superior attachment, superior articular process. This is the attachment of the flavum on the contralateral side. This is I'm on the contralateral side. So this is the right side of the patient. So once you chisel, so I use a chisel, then we remove it. So that becomes very easy rather than blind garrisoning of that area. We chisel it and remove the fragments in toto completely. So then we use the curate to curate out or curate the leftover ligamentum flavum. The So the work is almost complete. This is like a exploratory surgery most of the times. Biportal, we say this is a open surgery inside, but still ultra minimally invasive inside, because the scope gives us the advantage of corners like we do in endoscopic pituitary. You can go the put the scope inside and see those all those corners and arachnoid bulge. Similarly, in biportal endoscopy, the same thing can be done, which was not possible with microscopy. You cannot go inside the cella and see things. Like here we can go inside the canal and see things without compromising the integrity, which is the most important thing, so that we can avoid the fusions, especially in canal stenosis. So now in biportal we can do multi-level canal stenosis very easily. We can do hemilaminectomies very easily with biportal endoscopy. So all these elderly patients, 70s, 75, 80s, now are the patient who are willing for surgery, because we are saying we are not going to put a single screw on the back. If your integrity of the canal is intact, we can do this foraminal work, we can remove those flavum, we can still do multi-level hemilaminectomies, still your integrity of the spinous process will be intact, because the muscle interspinous ligament we don't touch. And all these elderly patients now are converting, and we are explaining this surgery as a cataract surgery. I say this, we are going to do a laparoscopy on the back. So they convert it. They feel that we are not having any blood loss on the back. You can see till the whole surgery, we don't see any blood, because the surgery is done in water irrigation. So we don't have lot of blood. So the even the having a post-operative hematoma is very, very less. The RF is the plasma which I'm using is also very, very safe on the nerves. So chances of having neural injury by the RF is very, very rare. So now you can very well see the everything, the thecal sac and everything here. So this is the RF which we are moving and clearing the soft tissue. This is almost the decompression is complete. Now once the decompression is complete, we'll move to the discal space. So you can see the disc here. I'm retracting. This is the retractor which I've inserted. You can see my assistant is holding the retractor, and I am just removing the flavum. We are removing some extra flavum, and then after that we'll remove the disc. So here, see, structural appreciation of unilateral biportal endoscopy is very, very good. You can appreciate the PLL, the crisscross fibers, everything of the disc. So you can differentiate. Sometimes you may have a large disc bulge. Sometimes the thecal sac is so much blanched that you think it's an annulus, not thecal sac. But here you can see structures very closely, because your eye go inside the body. So it becomes very easy for the surgeon to remove those discs and remove the things completely here. So you can see the disc bulge here. And we just expand the annulotomy with a Carrison little, so that you can remove the discs very well. You can do the work very precisely here, and you can see the disc coming out. You just compressed it a little and the disc comes out on its own. See, it is similar to the techniques and everything is similar to microscopic surgery, other than the scope which works as a suction and irrigation both. So if you simulate the microscopic surgery, it is the same way. We do hold a suction in one hand and the carison in the other hand and the instrument is in the other hand. So if you want to do a contralateral discectomy, you just have to dock on the contralateral side and do the surgery. So this is the discectomy which we have done. So water also, saline also help you to irrigate the discal space, and all those inflammatory mediators which are there will be removed. Suppose that doesn't have a large disc bulge, sometimes we do annuloplasty and end the surgery. But here the disc was quite bulged, it was compressing, so we remove the disc. But that's on choice. Annuloplasty, if the annulus is, there is no rent in the annulus, you can be very well done and the patients are doing well also. So some of the patients who are young and they want to play sports, we do not remove the disc, we just do annuloplasty if there is no rent in the annulus. So that they can play better. Sportsmen and all will help from without annuloplasty, only with shrinkage of the annulus with the plasma. So once we remove these big fragments, this is a big chunk of fragment which is getting relieved. So once we do the discectomy, we ensure all loose fragment to be removed. At the end of the surgery, we do this annuloplasty so that it shrinks the soft annulus, so that the chances of recurrence is also prevent. So the roots are free now. Both the contralateral and ipsilateral roots are free. So this surgery took us almost around 22 minutes. So this is a contralateral annuloplasty also, so that all these pack, the covering is shrunken and chances of having another um, uh, prolapse is reduced, and the annuloplasty also helps the all to remove all those nerves which are inflamed on the annulus. So you can see the integrity of the facets are very intact. This is the facet joint which is also intact, the capsule is intact, and this is a sewn space. You can see no muscle is damaged during the surgical process. So some of us say it is a lot of muscle is damaged in biportal, which is wrong, because we may be not doing an accurate UB. That is why. So this is the end of the procedure. So once the surgery is done, we put this you can see the water flow very well. You can see the flow of water in the skin. So you can see how small is the incision. This is a 4 incision, this is a 5 incision, and that's it. You don't need any big incision. Suppose we explain our patients who are elderly, you see them, so this incision, we'll do a laparoscopy on the back. They are very happily converting for the surgery, and we are able to clear them or get rid of this surgical very well. So once we do this, we put a drain at the end of the surgery. So you can see the saline irrigation here. So once we do, we put the drain. The drain is put at the end of the surgery. So this is how we put the drain. This is to the one port is used for the drain port. Then we tunnel it through the scopy portal and remove it through the scopy portal. The same portals will be converted to a drain port. You don't need, and the incision size is same as a drain port, so you don't need any extra drain port for the surgery. So we keep the drain for all these as a standard of care, because this is a water mediated surgery, so we keep it as a standard of care. So this is the surgical video. Now we move to the fusion slide. So I'll show you some of the fusion cases. So as we know, this is so can we see the fusion? So this is for how we do the fusion. So mainly the UB was designed beyond discectomies. So this is the intradiscal clearing we can do. You can go inside the discal space and clear those cartilaginous end plate from the bony end plate very easily by in UV. So the fusion bed is very nicely prepared in unilateral biportal endoscopy. So you can very well see the cartilaginous end plate from the bony end plate, so that a wonderful fusion bed is prepared. Sometimes in open surgery, we don't actually see the end plates. We don't know how much disc to be removed, but here the scope will go inside the discal space and remove all the discal space. So we call it the ultra minimally invasive spine surgery, not a MISS anymore. So you can see the incision is only for the screws. The cage goes through the portals, so you don't need any additional portal for the cage placement. You can see how much disc preparation has been done by unilateral biportal endoscopy. This is a dye injected after the discal preparation, and this is now we are following the dictum of dual cages. We are putting two cages for all cases of spondylolisthesis or fusion. So we put two cages. So we believe the end plates, we are putting a lot of fusion material. So fusion happens very, very early. So the disc volume is almost around for 13 to 14 ml, and we have removed 10 cc of the disc volume here. So you can see the ALL fibers also, which can be very easily sealed in the anterior border of the disc space. And the covering and all space preparation can be very well seen. So you can see from here 4.792 how we can augment to 9.64 the height of the discal space with biportal endoscopy with dual cages. You can see the both the cages and how much the interdiscal space is studded with fusion forming material and the fusion happening in this level. So you can see the this looks like olive. So it is like a bigger cage, two cages. We call it kissing cages. The cages are very close to each other. You can see the footprint of the cages here in the discal space. So the advantage is it is taking the load of both from pedicle to pedicle. From this pedicle to this pedicle, the load is coming. So you can very well see this. And this is the spondylolisthesis high grade, which we can see how we have augmented spondylolisthesis from here to here at this all levels. So this is a unilateral fusion, which you can see with one screw how we are achieving this fusion. This is my article on how we can with dual body fusion the tactics and nuances. This is how we put the end plate preparation and change the, you can see the very well prepared end plates. I tried to put two cages in open surgery and microscopic surgery. I find it very difficult, but it was very easy in biportal endoscopy because your eye goes very close to the discal space. The first cage is put inside, then we'll mobilize the cage medial or laterally, then we can rotate the cage. So you can see interdiscally how we can rotate the cages and put the alignment. So this is a cage which is rotated 90-degree, then another cage is also put. That will not only increase the lordosis, but also the fusion becomes faster. We are putting all cages. The problem with T-leaf that sometimes surgeons put the cage behind in the posterior one third. Here in biportal we can see inside, so we can put the cage anterior one third, so the fusion happens in the anterior part very well. So this is a rotation which we can do. We have rotated the cage, and cage playing with the cages are very easy in biportal endoscopy. Complete bloodless field is achieved. So again another case of how we do. So ipsilateral facetectomy can be done very well with biportal. We do bilateral facetectomies, so the facets and everything is removed well. Contralateral facetectomy also we do, so that the making the alignment with the facetectomy becomes very easy. Once you do a bilateral facetectomy from one side, it becomes very easy to align the listhesis. So this is a direct decompression. You can do foraminotomies as well. So this is how we are doing the, so you can see the contralateral SAP very well, and this is the IAP I'm removing on the contralateral side. So you can see the disc space. The real Cambin strangle is accessed through biportal endoscopy, because you can see the exiting route, the traversing route, and the end plates very well. So this is the exiting route area. Normally we don't see the exiting route, but here you can see exiting routes, because sometimes in high grade listhesis you get lot of scarring on the exiting route, which is we normally don't see. But here you can see the exiting route, traversing route, Cambin strangle very well. So this is the end of the surgery. You can see the fusion was done and how much fusion forming material, how much disc work, how much remove bone removal is possible with biportal endoscopy, that can be very well appreciated. This is another case of dual cage, how we can put the cages inside, and this you can see that there is a space was very small. The space was very small, but we'll augment it, put both the cages like this. First cage going in, then once the first case goes in, we rotate it to one side and put the second case. This is not from other side. This is not a P-leaf. This is a completely T-leaf procedure. Here we are not retracting the root. We are going through the Cambine's triangle. So here we'll push the first case to contralateral side. Once you put the first cage to contralateral side, then you put the second cage. So you can see how much space has been created here. This is the cage, complete cage. You can see it is placed anteriorly. This is the ALL which you can see in the deeper parts of the surgery. So then you put the second cage, the annulus, and both the cages. We call it kissing cages. And you can see how second case goes in. This is how the second case goes inside. And these looks like paired cages, as if they are one cage. But if you see a AP view, you can see both the cages in place. So this is augmentation which you have done. You can see the first slide. You see the bone, how down it is. There is no gap. There is no gap at all. But here we can have augmented the gap to this much level. So it is very easy to maneuver by portal endoscopy. This is a high grade listhesis. You can see, and there is no space. Again, we started with the fusion process, and you move the facet here. Again, I'll do this level. So you can see a scarce tissue in all these high grade listhesis. We can remove the scar tissues also. So this is the advantage of direct decompression, because sometimes in high grade listhesis, patient complains of back pain as well as radiculitis. The radiculitis is not only because of the foramen impingement, also because of this scar tissues. Once you remove this, do this neurolysis of this scar tissue, it becomes very well for the patient. The patient will be relieved of the radiculitis also after surgery. So this is another thing is the advantage of biportal. Here we can, in high grade listhesis, it's difficult to find the annulus, but here you can see things very closely. And in high grade listhesis, the Cambine's triangle is very small. So sometimes you may injure the Cambine's triangle, but the exiting route. But here you can see it from a very close perspective. So you can anyway modulate the area, work very nicely. This is a pseudo bulge which I'm working on. So I'll go inside and find a surprising finding in a high grade listhesis with spondylolysis. So you can see this we call as a Grand Canyon sign, because you don't have any space between the intervertebral disc, because the body was trying to fuse it, and the body was trying to fuse it in an abnormal way. So that it looks like, once you go to the interdiscal space, it looks like the wavy walls of the Grand Canyon. So we have to drill the, like an ACDF, we drill the osteophyte so that the cage can sit parallelly. Here also you can drill the end plates, and so that the cage will sit parallel. So you can see the uneven walls of the intradiscal space. It is uneven. The body was trying to fuse it. So all these are cortical bones. So we'll go inside and drill these spicules of bone so that the cage can be snugly fit. You can see the ALL very well here in the anterior part, but this walls looks very uneven. So putting a cage sometimes will not be snugly fit if you do like this. So once we go there, we'll see this looks like, this looks like the walls of a Grand Canyon. We'll go inside and drill the end plates with a disc. This was not possible in any other surgery, because you cannot go inside the disc plate without a scope. So we'll go there and drill it. So you can see the diamond drill and going there, and then we put the cage. Then we put the cage like this. So chances of having a neural injury is very less. The patients are psychological satisfied if you show them the videos, clear field, no blood loss. So they convert very easily with biportal endoscopy. So you can see how much augmentation was done with this. So this is how we put the cage. We don't put distractors or contralateral side distracting the cage. The cage itself distract. The maneuvers itself distract, and deduction it also happens with the cage. This is, you can see the fusion with unilateral fusion at the end of 1 year. So these are the dual cages which we have done. It looks like twin cages, which we call kissing cages. So this is the 3D recon of another case where you can see how much lamina and interdiscal work is possible with biportal endoscopy. You can see the completely the interdiscal space is studded with bone forming fusing material. No space is, all spaces are studded, so fusion happens very early. These are the 3 months results which we have produced. You can see the bone dust going in, how we can go and put the bone dust or bone fragment there. So you don't have need to retract anything, just go there, and through this the cage will go. So the bone material you can see there. So this is the, you can see, you can put the bone forming material anterior to the discal space where the fusion starts. So all these are bone thing, bone material which are going there. So how much space was made with biportal, and how clear it biportal is, so we see better, we work better, and this surgery becomes very very safe for the patient. You can see the exiting route here. This is the exiting route, and this is the Cambin's triangle. Normally we do not see the exiting route here, but with the power of the scope we can see the exiting route very well. So this is how then we put the cage. The cage goes like this with the same incision, using the elasticity of the skin, and the case goes in. It's very easy. It looks very difficult, but it is very very easy. Once we started doing biportal, it becomes very easy. Crystal clear cage without blood, clear vision. Washed, every debris is washed out with saline. No blood hampering your vision. No sagittal placement. No abjal placement. No retraction. Nothing. So this is a pure T leaf, no retraction, no P leaf game. So once we put the cage, then we put the second cage like this. First cage gone in, then we modulate the first cage to the second cage and put the second cage also. The surgery takes very very fast. Putting cage takes us 1 minute, 2 minutes like this. So whole decompression fusion takes 1 hour, 1.5 hour, half an hour for fusion, and for surgery one level it takes around 20 minutes. So the surgery is very very easy. This is our OT setup and our fellowship team which we work for this surgery. Thank you so much. Thanks for the patient listening.
Thank
So
you,
the,
Dr. Atmaranjan.
yes, please, Dr. Sachin, go ahead, please.
Yeah, thank you, Dr. Atmaranjan, for a wonderful demonstration. Uh, Obviously, unilateral biportal endoscopy is an obvious extension of microscopic surgery because you almost work the same way with left-handed suction oblique scope and right-handed instrument. And if you are doing either a microscopy or a tubular work, it may be easier for you to migrate to biportal endoscopy. What I think that's the message. So a lot of things look quite easy in the hands of experts, but for the benefit of wider audience and people who wish to start biportal endoscopy, uh, what are the initial challenges they may face, particularly with regard to reaching at the intended point, the triangulation, which is the one of the most important thing to reach at the proper place, and how to mitigate that. Number two, somebody had put a question about the fluid related complications and how to ensure that they are minimized. And number three is whether you would advise people to use the scope retractor or the working portal retractor in their initial few cases to keep open the outflow channel. So I would like you to tell us more about this, and then we can go ahead. Yeah.
As per the complication, fluid is definitely another matter which we are adding to the surgery, which was previously not there. It was air. So fluid related complication, we had two. One is the first surgery I had. Sometimes because fluid can pass through the muscular planes and go to the chest and back, so that it may cause some pleural effusion or abdominal area third space loss. So that has to be tackled, because that is because of inadequate. Sometimes when we started, the people are not trained. So trained staff is very first important thing. When whoever the person stands at the level of saline, he should be the same person which you use for the all the surgeries, because we use a pump for the surgery, and we ask the staff to pump it twice when we ask for the pump. So don't pump continuously. If we keep on pumping continuously, this the fluid may start sipping in. And what is the first sign we understand when the fluid starts extravasating is, once we palpate on the back, the back will be very hard. We cannot poke our fingers into the back because the fluid has moved in. Second thing, in the anesthetist, it plays a key role, because the PIP pressure will keep on increasing, because if there is a hydrostatic pressure reaching the lungs, they have to the machine has to push the air with pressure that will increase. Third thing is, one is seen is because the oxygenation is little changed, sometimes the blood color will also change during the surgery, that can be very faintly appreciated. So both the cases which we had, in the first case and one case 2 years back, those cases were kept on ventilator for 1 day, and next day all these third space fluids were removed. We started with Lasix, and all these surgeries now, we as a standard protocol, we give Lasix infusion as 5 ml per hour during the whole process of the surgery. This was for beginners, because now the surgery takes very less time for me, so I don't use Lasix anymore. But for a longer duration surgery, yes, we do use Lasix. Multi-level cases or fusion cases, we do. And second thing is the triangulation with midline biportal endoscopy. Rather than the unilateral, we stay on the midline now. We are not staying laterally. So that in the triangulation, what problem we face when we put the instrument, it start poking into the muscle and the fascia. So that is why what we are doing, we are cutting the muscle in a very wide cruciate manner. The incision remains small, the skin incision remains small, but the facial level incision, we make it little bigger, so that the water flows very nicely through this. And the second thing is, when we dock, we do not dock on the namaste point. We dock somehow in the upper part of the spinous process. The muscles multifidus are thicker. So once we go to above the namaste point, the muscle will be thicker, the bleeding will be more, and you won't get the plane. So once we stay on the namaste point, it becomes very easy, because you access the interlaminar window directly without going accessing the muscle. So we don't have any muscle damage during the surgery. It remains muscle splitting only.
Yeah. The other thing is whether to use a pressure pump at all, or gravity assisted irrigation is enough.
Sir, the pressure pump has a static pressure. Sometimes you may get a lot of bone dust, or sometimes you may need some, for transiently, some extra pressure. So changing those pressure pumps volume multiple times is very difficult and cumbersome. So instead we use a TURP pump. Mostly we use gravity, which helps very well. The pressure is very well. But whenever we need extra pressure, we have this TURP pump with a BP cuff on the handle. So the staff push it twice so that everything clears up suddenly. Then again we start working on this. This is especially when we have epidural bleeding or something, we need that. And then we release it once we identify the bleeder. Like we put saline and identify the bleeder in neurosurgery, similarly we push and identify the bleeder, coagulate it, and then we release it.
Yeah, so most of your surgery is gravity dependent, and if there is an undue bleeding, then you will use the pressure.
Pressure, sir.
Yeah. The other thing is,
Yes, sir.
in your one good point which you highlighted is you can get away with an annuloplasty in a contained disc, and that's a point very well taken. Uh, Regarding the fusion surgery, how far is your incision from the midline?
Sir, for the fusion, we are keeping the incision on the incisions are made on the area where we are going to put the screws after the surgery. So that is exactly on the pedicle, so that once we do the surgery, at the end of the surgery, same portals can be used for screw placement. So according to screws, we plan the portals, not according to the biportal way.
Okay, so basically on the where you are going to put the percutaneous screw, there's
Same
other.
points are used for the portals.
Okay, okay. but at times that's quite lateral to the midline. So in cases in which you have to simultaneously do a canal decompression along with a tea leaf, do you find any issue doing that through those sewing portal?
Because normally we do for canal stenosis midline incisions because it is very easy to access both the foramens well. But in fusion, anyway, we are going to remove the facets completely on ipsilateral side. So only we have to do the contralateral decompression because ipsilateral anyway we are going to remove the phlegm completely. For the contralateral decompression from ipsilateral side, once you put it in a distance, it becomes very easy to clear the contralateral side from the instrument portals, so it does not feel any difference. But some cases when we have a fusion along with a decompression at other level, suppose we have a L4-5 fusion as well as we have a L3-4 decompression, in those cases we met separate portals for the decompression.
So basically, fusion portal are lateral and the decompression portal uh,
Mid
closer to the midline at the higher level. But still, okay, so you will have two incision at the L4 level for that, one lateral and one medial.
medial.
Okay, okay.
Uh,
Uh, Smith, Dr. Jayesh, you can
Hi.
ask.
Uh, Very nice, Atma, as usual. So what I like something good about UB today so beautifully compared to Uniportal, because we are moving in the canal with the 4 mm scope only, and compared to other endoscopy in which it's 8.9, sometimes 6.9 for discoscope, and stenoscope it is 9.6 cannula. So the chances of damage to the dura with because of cannula and sudden jerk will be very less. As you rightly said, 4 mm you can go to the opposite side and underneath the facet, and you beautifully saw that contralateral facet drilling can also be done. That's what I like, because it's not possible from this side to opposite side to drill the contralateral facet. That is something which I like. Do you do annuloplasty in all the case? Means you coagulate annulus at the end in all the case?
All the cases are sometimes, because I have understood from all
It's
spine
very correct.
because most of the times the sinovertebral nerves are
Exactly.
there on the nerve. So once we do the annuloplasty, the pain-free status is better than no annuloplasty.
But sometimes patient have only radicular pain, which may not be because of annulus. Then maybe it may be exceptional. Otherwise, yeah, patient usually have back pain which will be subsided. Uh, you use drain in all the cases. Why?
Sir, because this is a water. It is not. We. I thought I used to have a imagination ki, because once we remove this pressure, there whatever some fluid or some blood will accumulate definitely, because it's a water irrigation channel and we don't know how much fluid has gone there and how much blood is collecting after the pressure is released. So we keep the drain for 12 hours and remove it on the same day, because the portals we use for drain portals only, we don't make additional portals for the drain. So psychologically I feel safer, so that is why I'm putting drain in all cases.
Then you
But
remove for
sometimes
next day. You remove on the next day, or
next day, sir, next day morning we'll remove. If we're discharging on the same day, we remove in the evening and discharge.
fine. As far as pressure is concerned, so do you tried arthroscope pump, that ortho pump?
Sir, initially I used, but I had, it was very cumbersome to change the pressure. Suppose we are doing it in 20 and suddenly we want some little pressure extra, some assistant has to come, we have to wait and he will change the pressure, then you'll start again, he have to ask them to reduce it. So instead, we use this TURP pump, which is very easy to handle. And sometimes we have in one surgery, suppose it takes 30 minutes, maybe we encounter bleeding in for 3-4 times, and maybe bone dust 3-4 times. So in 6 times, we have to change the pressure of the pump and all. But it is easier with the TURP pump to do
Right.
it
So,
faster.
so those who are just starting these things, just would like to highlight what Dr. Atma said. So there are three ways to apply the pressure at the canal. As like laparoscopy, we are using the air in the spinal canal. We to create a space, we use the pressure. So either you use the gravity induced pump, which is approximately 40 millimeter of mercury pressure. So if you are using the arthroscope, majority of the operation theater, whether it is a corporate level or the peripheral level, arthroscope orthopump is easily available. You can use that. If you use normally, you use 40 pressure, which is around almost all the gravity related. Sometimes if you find the bleeding, you can increase up to 60 in case of lumbar. In cervical spine and dorsal spine, if you are doing endoscopy, you have to use it less than 40 or gravity dependent only, because it may compress the canal and it may damage the cervical cord also. Right, Atma?
So it is better to, as a beginner, you should use a pump rather than matlab pressure channel than a pump, because sometimes the assistant who is standing there keep on pressing it.
Yeah, exactly.
It's
So
very fun for them to press the
to start
pump
with, it's better for
because he
ortho
is
pump.
standing alone and he is busy in pumping. Sometimes
Exactly.
it may cause extra vessation of fluid. So that's why we have fixed protocol of two puffs. You puff, then you release. That is what.
Yeah, very
So
nice.
is there any outflow channel also for this ingoing fluid?
Sir, the outflow is the working channel, and the inflow is the Scopy portal.
Yeah.
So
I mean, where does the water come from? Outside.
what
Where does it go?
this comes from the Scopy portal with a, sir. In normally we attached 4 units of saline. This will come. This is a irrigation system surgery. So
No,
all
Yeah.
this
But
fluid
where is the
he's
outflow?
asking outflow, outflow.
outflow comes out through this working portal. This will go through the Scopy portal and come out of the working portal,
Okay. Okay.
because this the saline comes out through the scope,
Yeah. Okay. Now I
like a
understand.
ETV scope.
Like a ETV procedure.
ATV,
Yes.
like a ATV.
Come and
Yeah,
come out.
same in uniportal also, because there is a difference between cannula and endoscope. The shape is different, so it's come through the same scope.
Same scope, sir.
So it's very important. You said that you never remove the facet for decompression also, for discectomy also. Is it good enough? Sometimes patient usually a superior articular facet.
Sir, for that we are doing under the caving. We just reshape the canal like a caver. We like a sub perio. We cave through the under lamina rather than removing the lamina or removing the facet. We just reshape the facets and canal. So that is why with the scope we can go underneath the lamina and modify the facets. We call it facetoplasty rather than removing the facet. We just undercut it.
Very nice. Now my last question. Uh, we all know that you are conducting the UBE fellowship program. Those who want to join international for UBE workshop, UBE short term or long term, your suggestion for them, those who want to do UBE fellowship.
Sir, we have a fellowship program for 7 days and 3 months. So definitely we our numbers are very high. So we do every day to 3 to 4 cases of UB. So it's roughly 50 to 60 cases a month. So those who are interested can be tried.
International,
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 I
somebody
believe
wants to
Dr.
go there.
Sohn and Dr. Park are offering fellowships in Korea.
Okay,
And I think the two are the highest volume surgeons in world.
very nice. So it would be nice if you can share their
So
email
my
ID.
one question is to Atman is, I mean, we have been hearing lots about this wonderful technique for over a decade now, and more so for last 5 years or so. Many people have started adopting this into their practice. But even after a decade of some new technique, what intrigues me is that it is not very popular among the spine surgeons. So, as compared to what a uniportal thing like a tubular or a microtubular discectomy or microtubular fusions. So, according to you now you have graduated and super graduated doing this for more than half a decade, perhaps. So, what do you think the reason is that it is not that popular as compared to what a tubular discectomy used to
Sir,
be?
it is a newer technique. Rather, I believe it almost started 5, 6, 7 years back. Only India it started almost in 2018 or 19. So it is a relatively newer technique than the monoportal. I believe Jay sir can tell this. So first thing is the all this Jay sir also will tell the industry driven things for implants. is definitely reduced with the endoscopic surgery, because we are doing multi-level without fusion and the patient recovery is excellent.
Yeah, that I
So
agree. Yeah, that I agree. I mean, you can to a certain extent also do non-fusion surgeries with the tubular
yeah.
this thing or retractors as well. So, but I mean, I don't know. I do not do UB. So I was
And it has
sort
a
of.
steep learning curve. That is one
Yes, maybe because it's a totally different immersive experience of using a UB operating from both the hands and looking on a monitor with the eyes inside. So maybe it's a different
Learning curve.
brain has to learn it actually.
and it's a free technique. So without damaging the muscles, going there will come up with some surgeries. So, but
Yeah.
initially, what people will do, they will cut the muscles, they go lost in the back rather than reaching to the spinal lamina junction. They will keep on playing with the multifidus and they are lost. So, that is the only problem in the beginning phases of surgeons who start biportal, they are lost. But with this midline biportal and the namaste sign and all, it becomes very easy. The triangulation is the biggest problem in biportal, which I believe in midline biportal, we have removed the triangulation step altogether by just creating two portal and reaching the same target at the namaste point makes the surgery very very easy, because we are also experimenting the surgeons who are coming here and learning the technique. For them it's become very easy to do this with the newer technique of triangulation, where we triangulate on namaste point and remove this triangulation system and docking system completely, which is a easier way.
Okay,
So,
perfect.
I,
That's
what
anything
I
else?
feel,
Yes.
what I feel,
Of the reasons which I believe, sir, is obviously we are tuned to use microscope as neurosurgeons, and
No. I'm not talking about microscope. I'm talking about those people who are doing endoscopic discectomies and endoscopic work. They are not. I mean, it's not very popular. I mean, UB, despite being in practice for last 5 or 6 years, people prefer to do endoscopic work with a uniportal approach rather than doing a biportal approach.
probably they are trained
I
that way.
think,
They are
yeah, I think it's a triangulation that needs to be learned and that needs to be.
Probably it is easier than monoportal because it's actually the natural extension of we are doing it by both the hands. In uniportal, your working instrument goes through the same channel, and it may be a bit restrictive compared to biportal. The visualization in both are very good. So probably biportal is easier and less cost intensive because the scope and the instruments are cheaper than monoportal. So it is just a matter of time that people will adapt to this. I think it's easier compared to monoportal, but I think its time is just not yet.
Yeah, I think it needs more training and
Yeah.
sort of a cadaver
Just one
survival.
thing to add, those this is really a game changer for patients almost around 70 to 80 years of age, who are the relatives are fearing for a surgery, a big incision, canal stenosis, multi-level. Those cases can be very well done with biportal endoscopy. Whenever they come, we show them the incision size and we say we are not going to put any screws on your back, and the surgery per level takes 20 minutes per level, so 1 hour 3 level can be done very well. There is no cutting, no closing, nothing needed. We'll just put banded on the back. They psychologically feel some different level experience ki we want this surgery and do it with us. And we tell ki we are not going to put any screws, so next day you can walk on the stairs, and we eventually make them walk on the stair on the same day. So which is also creates a lot of awareness. And with the regarding claudication, we tell them first, once you are free from this claudication, go there, go to the temple and send us a selfie. So they do that, and we believe that the awareness level goes to the next level with this.
That's Atmaranjan is true, but that's true for any minimally invasive procedure. Even tubular as well as monoportal will have small incision, less muscle dissection. So that's how means I think that may not be the selling point. That may be a marketing or sort of thing
Just
of convincing people, but That's actually scientifically is not no different between uniportal, biportal, and maybe even tubular. Tubular may have a bit more, but it's still minimal. It's not. We are not comparing open with uniportal. We are
No, no,
comparing.
no, no. Yeah,
mono-
of course,
Yeah.
yes. I mean, it's
Uh,
always between biportal and uniportal. No, this
Yes.
is
So
I just want to add that just with the smaller scope, we can access those blind spot in canal
yes,
stenosis.
that's a definite advantage that
So
I agree
especially on the
completely on this.
exiting
Yeah.
route,
Because
which do not
yeah.
decompress well, which can
look,
be very well decompressed.
exactly. I mean, it's impossible, as Jayesh also pointed out, it's impossible to reach to the contralateral route with the tubular monoportal thing. So that way, it is a clear-cut winner. So that is what.
And the clarity of this scope is a 4 scope, so it gives us a better visual perspective than a monoportal scope, because a monoportal camera is smaller camera. And third thing is the instruments in the mono biportal the instrument comes from another direction. In monoportal it comes like this. So if you want to
The
see the
angle is
content,
less.
you have to rotate it like this and see. But here it is like two people standing together, so you can see each other very well. So there is no blind spot of the instrument and camera overlap in biportal.
Overall, wonderfully presented and wonderful discussion.
Yeah. Yeah.
Uh,
So I think there are no questions in the chat box have already been answered. There are no other questions either. So a wonderful job, Atman. I mean, I would really congratulate you for this. And my only request to you is to train more and more people across to use Sachin also. I know that you've been doing this, and Jayesh also, and do cadaveric courses because I mean, these are the only thing that the youngsters can learn it better. So I think that it was a beautiful webinar to start with. I mean, a virtual one to start with. We shall be carrying on in the days to come with more such NESI virtual ORs with some modifications. Today, I really regret to to such a beautiful surgery, but I mean this was slightly being staggered in between because of the internet speed maybe perhaps. But so in the future what we will be doing for is to take the video before and then play it through our own internet so that it goes on seamlessly. So but anyway, these are learning points, so we will do it in future. Wonderful. Thank you, Atman. Thank you for everyone, and my co-moderator, Dr. Prakash. I hope he's here, and everyone, both the panelists, thank you for your time. And we shall look forward in future for more such interesting NESI webinars and virtual wars. Thank you very much.
Thank you so much. Thank you.
Thank you. Thank you, everybody.